Right. Good afternoon. Good afternoon, everybody. People are rolling in, but just to welcome you to our webinar to launch our latest STP guide on how to do this transformation. Really delighted to have some fantastic speakers to look at the community mental health framework and the transformation we're all undertaking. We have Claire Murdoch joining us first, who will speak and then take a couple of questions before sadly being whisked away to other equally important things. And we've also got Renica from the Making a Difference Alliance in North West London to talk about co-production, Jed Frankique from the West Midlands Combined Health Authority to give a view from a little bit nearer the ground about the transformation, and Becky Wardle, who are head of NHS collaboration, who's been leading our own work in Somerset, to talk to the guide itself. And at the end, we'll have time for questions from the other three speakers. You're all very, very welcome. It's amazing to think after a couple of years of thinking about almost nothing but the community mental health framework, we're now seeing the rollout across the country of new funds. It's really exciting. And while the transformation is ambitious, as we know, for NHS partners, it's also a real cue for the voluntary sector, for organisations like Rethink, to think about how we do things differently, not only in the way we work with the NHS, but how we work hand in hand in partnership through co-production and delivery with communities much better ourselves. So really exciting to share some of our thoughts and hear your questions. Without any further ado, may I pass over to Claire Murdoch, who needs no introduction, I'm sure, as the Director of Mental Health. So Claire, over to you.
Thank you, and thank you very much for asking me to speak again on this really important subject. I am incredibly excited about the expansion and improvement and change to community mental health services. Just to remind colleagues who joined the webinar this afternoon, we have 2.3 billion that we're investing in mental health by 2023-4. So we've basically got 3 more years of the long-term plan to go, and 900 million, nearly £1 billion actually, of that 2.3 billion is earmarked for this part of our national plan. So it's phenomenally important, and most of that 900 million flows this year, next year and the year after. So some of it has flowed in the first 2 years of our plan, but these years are years I consider that need to be big hitting years for landing what we need from our community mental health services development. So it's fantastic that you're focusing on this today. Obviously, we know that under community mental health services development, there are a whole range of work streams for people, for adults with mental illness or mental health problems. And it's really important that we advance all of them. I'm very minded at the moment, as we think about priorities, about the additional pressure that there is on, for example, eating disorder services, which appears to be linked, one of the consequences of the pandemic on people's mental health. And happily, in that context, we had absolutely seen expanding eating disorder services as part of this community mental health service development, as we have other aspects of, or other disorders, problems, challenges. I'm always sensitive about the words we use, but certainly for people with serious mental illness and mental health problems, and also people with that horrible label, personality disorder. It's really important that we make progress on all fronts there. And it's also really important, as you alluded to at the beginning, that this is a heavily partnership endeavour. The NHS may lead this. The money is coming through the NHS as part of our long-term plan, But we very much need our third sector partners, local communities. I'm really grateful for the thinking and work that Rethink and others are doing, for example, around some of the smaller local charities as well, and how when we work more locally with communities, it's going to be absolutely vital, particularly if we're going to press into the equalities agenda in mental health. It's going to be absolutely vital that we work with different sections of communities, and the role that small and large charities play in that is going to be a pivotal part of the partnership. In terms of priorities currently, I mean, thank you everyone for what you've been doing over this last year. Almost by definition, everyone on this call will be folk who have worried about, thought about, worked on and delivered a safety net, outreach, care, treatment to people with serious mental illness during what certainly is the most extraordinary period of my 37 years of working in the NHS and my 60 years of life. And so thank you to you all. I think it's been a real partnership endeavour. We do know, of course, that for some people, actually, the lockdown that we've all experienced, including the most recent one, has brought some strange benefits. Or, you know, I do hear some people saying, actually, I've really liked having a less busy social calendar. I've liked being at home more. I've liked spending more time with my kids. And I think we shouldn't lose what people have seen as positives from this period, because I think we need to learn from it to help inform our thinking about well-being as a society going forward. However, let's be in no doubt that for many people, it's been such a challenging time. People living alone in poor housing, unable to do the things that have kept them, you know, helped them keep mentally well, emotionally well. And I think how, in terms of looking at priorities for this coming year, what we do right now actually as we unlock, as it were, and how we make sure that we're engaging and working with and alongside and co-producing with some of our more vulnerable service users and ones that have been harder hit by COVID, I think is pivotally important. We have the long-term plan. We have to now look through the lens always of the year that people have just had. And of course, we're going to be living with COVID for some time to come. So we're pivoting the long-term plan. Still, it's not that our priorities have changed, but how we work might be different. Drawing on lessons we've learned around the use of volunteers, peer support workers, the use of digital, community activation and support during this time, the strengthening partnership between the NHS third sector, social care and others. We mustn't lose those lessons. So thank you for what you've done. Please be in the mode of reflecting as we implement the community mental health service element of the long-term plan about, well, what will look slightly different as a result of what we've learned. Clearly in the coming year and right now, we've been really grateful to Rethink and other partners around the vaccine. We have to get the vaccine to as many of our service users as we possibly can. We know there are heightened risk factors for many people who have a serious mental illness or serious mental health problems, and the vaccine is key to protecting and promoting their health over the coming year. We're not making bad progress. I do want every area of the country working in partnership with third sector, families and others, primary care, to make sure we reach everyone. It seems to me to be pivotally and immediately important. As the NHS, we're really involved right now in making sure that the money that should be flowing from this year onwards is flowing. So we've asked all of the ICS systems and CCGs across the country to create plans and submit plans so that we are able to see, and more importantly, they and local people are able to see that the money we've got for investment this year is actually flowing to the areas that we need it to flow to reach as many people as possible. And of course, the community services investment is something I was talking with my teams about only this morning. We'll be looking really closely at, can all areas evidence that the investment is flowing? So that's a major immediate priority. Of course, the best areas are already well advanced in their community mental health team plans. They're learning from the pilot areas and the work that colleagues did throughout the last year and before, and they're already out to recruitment for new posts and different ways of working. So we really need to see that driven hard. Obviously, in the coming year as well, I should just say on that, of course, we've had the additional 500 million from government in the spending review on top of the LTP monies for this year to help us get back on trajectory, on track with our long-term plan objectives. And so we're delighted about that. 100 million of that, 110 million of that is going to mental health workforce and joint work with Health Education England on that. But the other 400 million is out into the system. We wrote to ICS Systems about 2 weeks ago detailing what the money is, what they're getting, and which of the programmes it will support. So we've had that additional boost as well. Over the coming year, also, we will be working closely with government and other partners, as we've done in the past, around the development of the new Mental Health Act. We're moving from a risk-based system of mental health law into a rights-based system of mental health law, where the views and wishes of service users will be infinitely stronger, we all hope. And it's going to be really important that we understand the full scope of the new legislation and that we're ready across the country to implement as swiftly and as effectively as we possibly can. And that's going to be really important, working with local authority and other partners, but certainly with service user groups, our charity colleagues and others. I've been really pleased that in recent times government have published their cross-government mental health plan, looking at the role of each government department in delivering better mental health. I don't want the NHS and diagnosis and treatment to be the first port of call in most instances for mental health and those with a serious mental health problem. Obviously, we want to be here, doors open. We've worked hard throughout the pandemic. We've introduced our 24/7 crisis lines. Our talking therapies have shifted online. We've innovated in all sorts of ways. We've prioritised children and mental health services. Of course, we're here, and of course, we know we have an important part to play. But Rethink and other charities are superb at highlighting this. Good housing, looking at universal credit, opportunities for work, looking at the role of education, employers and others, looking cross-governmentally so that every government department has a part to play in promoting better wellbeing, even death for our use of countryside, outside spaces and so on and so forth, is incredibly important, health and justice. And all of the other government departments. So we were pleased to be part of working on that cross-government mental health strategy, and we want to really prioritise that. And we need to prioritise out of area placements. We've seen a slight increase again. We were making great progress in reducing them prior to this past year. We know that some beds, just as across the whole NHS, have had to close because of IPC, infection control, COVID and so on and so forth. And some of that has resulted in out of area placements in some areas going up. We are giving that a fierce focus because local care is generally always better care, nearly always better care. Workforce and continuing to create new roles, particularly peer support workers, apprenticeships, different routes into mental health, as well as nursing and the more traditional professions is a major priority. We've learned a lot around what digital can do. It's never, if something looks too good to be true, in my experience, it always is. So digital is not the magic bullet for everything. But you know what? We've learned a lot, and I think it's going to be really important that we continue to drive digital innovation, particularly where it provides more choice, a wider range of therapies, easier access and so on and so forth. But let's not think that's everything. And driving innovation in the community mental health team model. None of us is about doing more of the same in most cases. This is all about doing it differently. I guess that's a bit of a flavour of some of our priorities for this year. I think I've probably said enough at this point, mindful of time, and you have a lot to get through. But I'll end where, more or less where I started, which is to say a huge thank you to all of you. We need to be insistent, relentless, enthusiastic, high energy, because this is a chance of generation that many of you and we have been fighting for, to improve and strengthen vital community mental health services. So thank you for what you have done, and even more importantly, thank you for what you are doing and will be doing this year.
Thank you so much, Claire, on behalf of everyone listening. And we're just going to detain you, if we can, for a couple of quick questions. I just want to, I think that post-pandemic, looking at the kind of levels of need that we're beginning to see coming into the system of distress, and I think the community mental health framework and that kind of deep partnership with the community, unlocking its assets, always looked like the best answer, but it sort of now looks like the only answer possible. Yet at the same time, it is really hard with everything else going on, and with the sheer physical restrictions of the pandemic, to kind of form those deep partnerships needed. And I just wondered if you'd have anything to say to an area that might have found, or might be feeling it's a little bit behind the curve in building the relationships with the community, the voluntary sector, and the local authorities.
Yeah, you're so right. Look, we know that there was a pre-existing treatment gap and pressure on services, and more importantly, face it the other way, that people had problems accessing services when they needed them, or the kinds of services that they needed. And that's what the LTP is all about, addressing, closing that treatment gap and doing it innovatively. Now we've had COVID, and we know that there's been a surge in mental health demand and need. What we don't know for sure is the extent to which some of that will subside when people's lives return a bit more to normal, and they can see family and friends more readily and easily, can return to some of the fantastic face-to-face groups and work and support that third sector organisations, community groups and others offer, as well as more easily and readily seeing their clinicians and others face to face, as well as digitally. So it seems to me, I've always been clear about this, I am more clear about this than ever. The NHS cannot do this alone, and has to, as we move to the ICS partnerships and the new operating model for the NHS. At its heart, integration, localism, community engagement, sits. And so the most effective ICSs and systems, and it's great some of the work that you've been helping to do in Somerset, I'm so glad you're looking at that later today. It's absolutely essential that we look at prevention, self-help, peer support, community support, as well as easier access to NHS services, assessment and treatment when needed. And I just don't think we can respond in the way we need to as a society unless everybody plays a part, and we, the NHS, are very savvy about how we work with our partners. I would just also add that beyond our partnerships in the mental health world, I do think, and we lobby quite hard on this, that others have to really step up to their responsibilities, whether that's the social media giants, gambling companies, some of the companies that make, I don't know, diet lollipops for children. I ask you, we're seeing these big pressures on eating disorder services. We really need industry advertisers, social media and others to step up and play their part too, and stop stoking some of the worst excesses of mental and emotional pressure on people. So partnership pivotal, and we, the NHS, have to get even savvier about how we draw on local resource and work with people and through people. There simply are lots of things that other sectors do better than us, do more appropriately than us, and when you combine their strengths and capabilities with our strengths and capabilities, you've got some liquid gold there then. So we're going to need that more than ever.
Brilliant, thank you very much. And one more question, if I can. So we've got quite a few questions coming in about learning disabilities, autism, and the sort of transition around children and young people. So sort of the fit of those things into the community mental health framework. I don't know if there's anything you wanted to say on those two areas.
Yeah, so yeah, a couple of things. Yeah, so I've very much focused on the mental health programme here this morning. Oh, this afternoon, isn't it? The time's gone quickly. But I and colleagues are hugely thoughtful about the opportunities to change the model of care, particularly around the interfaces between mental health, learning disability and autism, of which there are many interfaces, whether that's better physical health and annual health checks, whether that's about quality of inpatient care and indeed avoiding admission to hospitals and strengthening what's available in the community. 31 million of the 400 million has been earmarked specifically for learning disability and autism additionality this year from the spending review, and we are investing quite a lot of new money this year in things like key workers for children and young people in learning disability and autism. The government's about to launch an autism strategy, and we are investing heavily in the mental health support teams in schools. Now, although they won't be specialist teams because they are for youngsters with mild to moderate problems, we confidently predict, and we're training for this, that sometimes those teams will be referred youngsters who haven't been previously diagnosed, and they might get, I don't know, referred for conduct problems or behavioural problems, and they may well have autism. So we're hoping that embedding mental health support teams in schools will be a vital part of flagging and working with parents, schools, primary care and others to identify issues and challenges sooner for youngsters, particularly with autism, but also a learning disability. So I think that there is lots of crossover. We're doing some training modules in our children and young people's IAPT services for how to make sure, and adults actually, how to make sure that talking therapies can be available too, and reasonably adjusted for people with a learning disability or autism. I'm really keen over the coming year or two to forge far closer relationships across the programmes where it makes sense. So I'm really aware we're talking about often different populations and different needs, but actually sometimes there's a big overlap, and parents, carers and individuals themselves will know sometimes we carve up their different needs and silo off the services in ways that don't help. So I'm really looking forward to sort of driving closer integration there. And as you know, we're giving big focus, and the community mental health team development that you're focusing on more today is part of this. We're giving big focus to changing the transition and service models so that we don't see this weird cut-off at 18 and suddenly you're an adult the next day. You have one set of services until your 18th birthday, and they all change when you're 19 or 20. So that's a really important part of the community mental health services development piece.
Brilliant. Thank you so much again. It's been great to hear your reflections, and I think we've all sort of praised the community mental health framework before. I just also reflect that it's now been 2.5 years we've been working on this, and it's I think for us and other charities, we really feel that we've been invited along on the journey with you, and I think that's a real kind of reflection of your leadership. And so thank you again for your time today.
Thank you. Can I just say the community services framework is a thing of beauty. It's wonderful. And whilst I'm really proud to be a part of it, actually, it's a thing of beauty because it's been co-produced. We've drawn on the best expertise across the country outside of the NHS, partners like you, people with lived experience. And you're absolutely right that we've designed it together. It's not our plan, it's not the NHS plan, it's all of our plan, and that's why it's so vital we implement it in partnership and we drive it locally in partnership. So a huge thanks to you and everyone else who created what is a great plan. Now we've got to create great delivery.
Thank you very much indeed.
Thank you. Goodbye everyone. Good luck.
Brilliant. Thank you. Thank you for that. I'm now going to move on to Renica, who sits within the Making a Difference Alliance in North West London to talk about, and we're going to talk through co-production. It's an absolutely critical plank of delivering this. Hi, Renica.
Hello. Hi. Thank you for having me speak. I appreciate it.
You're very, very welcome. And you've been working in co-production for some time now, I think.
Yes, I have. Yes. I initially I was brought in as an expert by experience by NSON, along with some other members from the North West London boroughs, basically to form a leadership group. It was to establish in 2014, 2015 a culture of co-production at all levels of commissioning and influence. In the provision of mental health care and support across North West London. So I was lucky enough to be interviewed, and given this amazing training, which it taught me how to not only sort of draw on my individual experience, but also our collective experience, and use this to advise the North West London Mental Health and Wellbeing Transformation Board. So, you know, although we've all can draw on our own experiences, I found that the training helped me to get a better understanding of this huge complex beast that the NHS is, and basically all the different moving parts and where we could be as effective in the shortest amount of time. And basically Making a Difference Alliance evolved as a pretty dynamic group, powered up and fully committed to rapid transformation. Prior to this, I've been involved in service user engagement, which frankly, I just found it so disempowering and destructive. I did meet some amazing people there, but the system didn't help at all. It couldn't. It was set in another kind of mindset.
So just for our audience today, if there's sort of co-production that really works, and people really wanted to kind of make use of it quickly in this transformation, are there any kind of tips that you'd pull out from your point of view, really making it like your second experience rather than your first experience?
Yes, definitely. So I think, with co-production, one of the things is to think about in terms of like the army, and it's sort of a military point of view. You kind of need to make sure that, as opposed to service engagement, where you can bring in people, bring them in, take them out, whatever. In co-production, you use the power of the group. So if you can train your group to actually be able to discuss at high level, their information, so that you're not wasting other people's time. That's really important, because otherwise people just switch off, and that doesn't help anybody. I found that working with CNWL, because they were so committed that we were going to do this properly, they invested the time and the money. And the thing is, co-production does take time. So my big point would be, give it time. Don't think you can do this at the last minute, because then it would be a disaster and you're going to ruffle a lot of feathers. Basically, you want to get the information out as quickly, as early as possible. You want to do task and finish. I've noticed time and time again that when you do task and finish projects, you get the most bang for your buck. And you've also got the oversight of the co-production people who, remember what the conversations were in the beginning, and they can sometimes do things that it's harder for NHS people within the system to do, because they're not part of the system. It's easier for them to voice concerns, and sometimes it can be for staff inside. So I would say that's critical. I have got, for me and others that I talk to, a big thing is it's connected with the task and finish, is avoid falling into epistemic exploitation trap. And this is where essentially you're just kind of extracting information from people, dropping them. Everything is very kind of incoherent. You're not really part of the journey. You know, co-production people are, you know, they have they're people, they're not commodities. So you need to bring them along with them. They tend to invest a lot of themselves into this. And I think the more respectful the other side is with communications, and that is tiny little things. It's just like getting the papers and the minutes out to you on time. It's a small thing, but it means a lot to people who are usually under-resourced themselves in shorter time. So, you know, that works.
I suppose too, if the papers are dealt with, it sort of establishes both that the meeting is as important as any other meeting, but equally gives people time to reflect and to talk to other people and bring in their experience as well.
Exactly, because that's what I like to do. I like to get feedback. I don't just want to be, you know, talking about me personally. That gets really boring. So I want to bring in the community voices, and that takes a few phone calls, saying what do you think about this, if anything happening, you know, and you just bring it all together. So that's, you know, that works wonderfully well. I've seen it so many times. The other thing I've found that is amazing is having, if you've got a co-production unit and they have their own meetings, they provide a lot of backup and encouragement then, because within the system of the NHS, you're basically kind of in and out of meetings and people's and little groups of people. There's nothing consistent in it. If you have a consistent group, it kind of gives you a bedrock. And if that group is constantly learning and improving itself, it just keeps everybody on their game. It keeps them motivated. That's huge. And the other one is, if you do co-production, I say minimum number really is 3 people, because it allows you then to unpack things between themselves, and kind of if somebody can't make one day, you know, another person can step in. It's you can't. That's what I've discovered is the best kind of way of doing it so far.
There's really strong themes there about relationships and both between people who are all engaged in co-production and between them and the organisation they're working with. It's not transactional. It's supported by training. But I just wondered if I could ask you one more thing. I know you were involved in some of the post-Grenfell work. How do you have any kind of reflections on how to make sure that co-production reaches out, as you say, to all communities and particularly underserved communities?
It's really interesting. You have to. I felt in the Grenfell one, you had to be really innovative. It happened by chance. I was asked to do an equalities impact assessment for some work for them, and I did this. But rather than just use the normal language or normal statistics, I went off and did my own research and stuff. And I was able to put things across in, you know, and data across in a very vivid way, and just say, look, guys, you have to take care of this, because if you don't, you're ignoring all this kind of information that we know is rock solid. And suddenly I got whisked into some super secret meeting. And I think what you were facing there, the difficulty is one, people seeing the problem, because they've never experienced it themselves. They really genuinely can't believe it exists, and it gets stuck in a bucket of people who are being difficult. I was able somehow to get through by talking, and also by saying, you know, with the BAME issues, look, it's beyond us. I brought in the dating, the evidence in the dating programs on Channel 4 and stuff, where they were using scientific equipment with experiments that they were running. And I just said, this stuff is happening in a second, in an instant, but it's causing a lifetime of damage. And I think, so basically we all have to be advocates. I think every single one of us in the service really has to step up and be an advocate for people who don't have a voice, don't have the contacts. And if they do make contact with somebody, they're suddenly slung into a box. So you've got to say things like, actually, you know, somebody's cognitive bias can kick off in a millisecond. It's nothing to do with how good you are as a person or whatever. It's just the culture that you've been exposed to. So let's, you know, if we can find people who are local, who have trust, who are people that people gravitate towards. They like to listen to them because they've got engaging personalities, they've got enthusiasm, and they trust them. And Claire was mentioning at the beginning about the uptake of the vaccine. I mean, in the BAME community, there are so many, I would say, valid reasons for why people are slow to take this up. And unless you know the history of them, you would just think it's crazy, it's silly. But so the only way, and it's trust that creates trust. You know, if you're, I just think, you know, the connection with the local GP, you know, that's a hub, and involving people locally more and more in innovative ways. Don't stick to just using a very cumbersome paper-led process. You know, make it easy. Set up drop-ins, put up things for people and say, oh, if you've got time, you know, drop in and come and chat to us. We're interested to talk to people who want to improve the community in health or whatever, and just make these random connections. And I think from that, you can't always keep going to just people that you know.
Agree, Renica. Thank you. Always connect, always build out, always build the relationship. Well, thank you so much for giving us your reflections, and look forward to coming back to it with the questions at the end. Thank you very much. I'm going to move now on to Jed, if I may.
Hi, my name is Jed Franceek. I'm going to give a perspective on what we did in Coventry and Warwickshire to respond to the beautiful opportunity that the community mental health transformation provided. So that's what I'm going to talk about briefly. So in terms of the probably move on to the next slide. In terms of the grounds I'm going to cover, I'm going to talk about community mental health transformation in terms of our approach and what we feel it isn't. I'm going to give you some feedback on what I think ought to be an article of faith for organisations working locally. I'm going to give you a little bit of some thoughts in terms of the journey, for better or for worse. I'm going to talk to you about making lemonade, and finally, I'm going to touch on the relevance of jazz to all of this. So moving on to the next slide. Community mental health transformation, what it's not. I think when kind of documentation came out, it was really tempting for local organisations, the NHS trusts, of which I belong to kind of look at it and think, well, is this about kind of tinkering at the edges? But obviously, this is not about the status quo. This is not about tinkering at the edges. This is about something much more fundamental in terms of change. So it's not about status quo. The dinosaur that some people wanted to dig up. So, for example, some of the conversations that emerged when community mental health transformation proposals emerged from NHSC were, well, actually, we can recreate community mental health teams from 1987. So one of the things that's important, I think it was important for us to kind of reflect on was, yes, community mental health teams have been brilliant in the past, but we need to think about not resurrecting a dinosaur, but making things relevant for current circumstances. So don't dig up dinosaurs. In terms of the top secret point, there's a lot of clever people in each local system, and it sometimes can be tempting to get one of those clever people to lock themselves in a darkened room for 2 weeks and develop a plan in isolation. Probably need to feed them raw meat and apple juice or something every once in a while, but then for them to emerge from kind of this secret bunker and say, here's a brilliant plan. So no, we don't want that. So it can't be something that's top secret. And finally on this, it's not about just involving the usual suspects. Just because we in the Mental Health Trust, for example, feel comfortable working with stakeholder X or stakeholder Y, it's not about that. It's about thinking more broadly about who is best placed to support this agenda moving forward. So next slide, please. The article of faith. You have to really, really, really believe in meaningful collaboration. I mean, this point has been touched on already. There's a range of different parties, a range of different stakeholders who've got a range of brilliant strengths that they can bring to this agenda. You know, and again, using the kind of a Marvel analogy, if, you know, in Infinity War, not any one of these individual superheroes, be it Hulk or Black Panther or Iron Man, not one of them individually could save the world. It was about collective endeavour. So there was something about us in the NHS, something about us as system partners, really, really believing in the benefits, the huge benefits of multi-agency, multi-sector working, really believing in the importance of a collective response, really believing in developing a system where partners have got equal value and those different strengths and different qualities are respected. And that's ultimately the only way that we can get to a place where we're meaningfully co-designing and co-developing and co-delivering a system that really does meet diverse needs of local people. So there's an article of faith where we really believe in meaningful collaboration. That's got to be at the heart of it. Next slide, please. So even if we believe in meaningful collaboration, there's always going to be bumps along the road. It's always going to be difficult. So there is something about committing to the journey for better or for worse. We really have got to commit to that journey. And what that means is creating structures, arrangements and processes where together as partners, and that includes, you know, housing, voluntary community sector partners, experts by experience, etc. We actually generate ideas together. We talk about money together. We design processes and systems together. We make decisions together. We celebrate successes together, and we also deal with some of the challenges together. We've got to have that system where we stick together for better or for worse. And I also think there is a trap that it's sometimes easy for us to fall into, where we say, actually, as an NHS trust or any other anchor institution, we want to get our house in order first. And I think, personally, I think it's a trap. I think the world keeps on changing. We just need to collaborate and work through things together. So we've got to commit to the journey. We know broadly where we're going, to Oz, obviously. And we've got to acknowledge trust issues, skepticism, old ways of working, etc. We've got to acknowledge what those barriers are, or those challenges are, but work through them together and stick together and maintain this collaboration. So next slide, please. And the pandemic, you could argue, is you know, when life gives you lemons. I mean, you could say that kind of COVID, the pandemic, is the grandmother of all lemons, fields of trees of lemons, arguably. So, but the argument is, if life gives you lemons, make lemonade. I mean, we have to look at this as an opportunity and see actually how to get the best out of the situation. And what that means is, again, from a collaborative system point of view, NHS partners, voluntary community sector partners, housing, social care, etc. We've got to pull together, not pull apart. It's easy for us to pull apart, but we've got to pull together, and we've got to hold our nerve and believe that collaboration is the right thing. So next one, please. And finally, really, this is about radical change. And I think what we've got to be prepared to do is improvise. I mean, whatever brilliant plans we've come up with, you know, things will change. You know, who could have predicted the pandemic? You know, we need to be willing to improvise. If we're really committed to providing and delivering place-based, personalised, holistic care that's really needed by diverse communities, we've got to also be prepared to improvise. And obviously, this is the relevance of jazz. You know, we've got to kind of be experts in our own field, instruments, whatever, and we've got to practice together so that we've got a good framework for when things change and develop, we can move and respond and improvise and innovate together. And obviously, the age-old adage, doing the same things and expecting different results is insanity. And who would want, excuse the expression, an insane approach to delivering community mental health transformation? So that in large part is kind of the thoughts from the West Midlands. So next slide. That's all, folks.
Jed, thank you so much. I'm just going to introduce Becky in a second with the sort of challenge, follow that. But just to say, really enjoyed that. It's rare that you get 2 or 3 texts saying how much you enjoyed, how much people are enjoying the speaker, even while they're still on. Thank you. Can I introduce my colleague Becky Wardle, our head of NHS collaboration, to talk through some of the main points in the STP guide that we've just published.
Thanks, Will, and you're absolutely right. What an act to follow. I'm clearly not going to measure up, but I'll do my absolute best. Yeah, really fantastic to hear from the speakers so far, Claire, Murdoch and Jed. And I think for me, I mean, there's so much there, isn't there, about partnership, doing things differently, community, collaboration, co-production, and the fact that this is such a big task and we can't do it on our own. I mean, Rethink have been absolutely supportive of the commitments made in the NHS Long Term Plan and the Community Mental Health Framework, of course. And I mean, similar to the comment that Claire made, we agree this is really a once in a generation opportunity to transform community mental health services for the better. But as Jed has said, this is not easy. This is kind of big transformational change. And I think sometimes it can be really hard to know where to start with that. So, I mean, we really know about this kind of firsthand. I think probably many of you may know that we're the lead accountable organisation of a voluntary sector alliance within the Somerset Early Implementer site. So we've been working collectively with the NHS and the local authority to deliver a new joined up and person-centred model of care kind of within that. So we've got that first-hand experience which we're bringing. Could we just go on to the slide deck? Thank you, that's great. So we've kind of used that expertise and the learning that we have gained and obviously still gaining from that direct involvement in Somerset, and also research looking at other early implementer sites and areas of good practice. And we've produced now 2 guides which are designed to support STPs and integrated care systems to deliver their version of community mental health transformation. So our first guide was called Thinking Differently, and that was launched in October last year. Some of you might be familiar with that already. And that really detailed and set out the first 5 steps that areas would have needed to start to take to begin that journey. So convening system leaders to really kind of drive that forward, thinking about starting to co-produce, community asset mapping, beginning some work around alliance building, and also starting to have those initial thoughts about workforce. But I'm here today to talk more about actually our newest guide, which launched back in February, which is called Keep Thinking Differently. And the guide really follows directly on from that initial guide, but really gets into troubleshooting issues that may have surfaced when trying to go through those first 5 steps, and then moves on also to kind of outlining a path towards that ongoing delivery. So today, over the next 7 minutes or so, I'm just going to take you through a fairly whistle-stop tour of the guide and outline the next 5 steps that are really going to support and enable community mental health transformation. Next slide. Great. So as I said, that first step is really a focus on troubleshooting. So what challenges, what hurdles may have surfaced so far, perhaps whilst beginning co-production with experts by experience, perhaps whilst bringing an alliance of voluntary sector partners to work with the NHS and with social care, or perhaps actually bringing the local authority on board in order to bring about change. So also perhaps challenges may have been experienced in trying to enact this level of change. As Jed said, this is big, this is kind of really big change that we're talking about. I think that the kind of clear thing to say is that you're definitely not alone. And what we've been hearing across the country from systems that we've been talking to and experience in Somerset is that common barriers really exist in systems across the country, and it's really important to identify these, I think, face them head on, and also then obviously kind of identify collectively solutions in order to enable that progress forward. So the guide just discusses some common roadblocks such as scepticism, resistance to change, lack of trust, I think often concerns around cost funding, and the guide just digs into that a little bit, thinking about some tips and examples kind of practically about how these can be overcome. Next slide. So moving on to think about measurement and evaluation. Of course, it's absolutely vital to measure and evaluate the efficacy of a model. So we need to know that it works and that it's doing what it set out to achieve. I think what our learning has told us is that actually this is really important to do, but do it without rigid targets that actually could have the effect of undermining the person-centered nature of what you're trying to achieve and setting out to do. So this section of the guide just gets into some examples of what kind of measurements you might want to use, gives a little bit of detail about some of the metrics and the impact measurement that we've co-produced in Somerset. So just using that as an example. And that includes a mix of the nationally mandated measures, but also locally developed ones. So bringing those together into one framework, showing some of them showing that kind of wider system impact, looking at kind of whole system capacity and demand, throughput, waiting times, all of those things that we're very, very used to kind of reporting on and recording on, but crucially also thinking about holistic, person-centered measures that can really demonstrate outcomes and impact for people and the communities that they're living in. And on to the third. Yeah, so the third step in this guide goes on to talk about that, you know, absolutely critical element, but one which can cause perhaps some headaches sometimes, which is around commissioning and contracting. And obviously, as we've heard today, I think it's kind of come through from all of the speakers, successful transformation can only be really achieved in line with the framework by developing voluntary sector-led services as a really kind of integrated and integral part of the local mental health systems, and actually identifying how that funding is going to flow down to the voluntary sector partners and then communicating that out to the voluntary sector is really key. And I think kind of starting to grapple with that, think differently and move away from perhaps more traditional forms of contracting that can really end up actually contributing in and of itself to the transformation. And I think there's just something there about statutory partners having to start to be a bit comfortable with some challenging things, such as potentially giving away a bit of leadership, power, funding for the greater good in terms of the transformation. So in the guide, we just talk through some of the ways in which voluntary sector organisations could be commissioned in order to work in partnership. And there's some examples in there from Somerset again, but also from Lambeth, just thinking about different ways this could be approached. There isn't just one solution to that. And next slide. So the fourth step is recruitment and skills development. Obviously, such an important part. We need to make sure that we have the right people in place with the right skills to be part of this solution. And our practice and our research has shown actually that people affected by mental illness themselves cite a really broad range of roles as being really core and vital to keep them well. So the guide talks through some of those roles, which might be not the more traditional roles that you might think of, and also how they line up with Health Education England's new roles for mental health initiative, and also the NHS England social prescribing kind of rollout and planning. So we also kind of look into and get into a little bit more detail about skills, key competencies for staff that might be working as part of the new model, and also the function of training, development, learning opportunities in supporting that kind of longer term. And on to the final stage. So the final stage in this second guide is moving on to the crucial and critical part, obviously kind of co-delivery. So once all of those other steps have been taken, it's time to start delivering the new model. But I think one of the really important things to remember is that isn't going to be the end of the journey. So again, kind of as everybody has said, this is massive, big transformational change that we're talking about. This isn't just shifting around some furniture or tinkering around at the edges, I think was the phrase that Jed used. And I can't really kind of emphasize enough how much this is going to be an iterative process. Co-production partners are going to need to continue to meet. Community is going to need to continue to be engaged in order to keep developing and keep evolving and iterating the model. So that was the guide. So that just really outlines the next kind of key steps that all areas are now going to need to be taking in order to successfully implement the transformation and the implementation of the community mental health framework. And really just the final thing that I just wanted to let people know about is Rethink's new community mental health unit, which I'm really proud to be a part of. And I'm joined in the unit by some fantastic new colleagues. We have Helen Garnham, Kenise Shaid and Mark Trewin, who have recently joined the team at Rethink, which is really fantastic. And we're all working obviously with other fantastic colleagues at Rethink in our co-production team. And of course, Will, who is our chair for today. And the unit really is a centre of expertise, I guess, in all of those kind of crucial elements that will enable transformation. So co-production, voluntary sector alliance building, all those things that we've spoken about today, community engagement, tackling inequalities, health inequalities, and really enabling kind of collaboration and partnership with the NHS and social care. We're currently partnered in 4 new areas across the country. I think we'll be able to share details of those in due course, but maybe not quite yet. We're working in those areas, actually also beginning to support in some other areas as well, along with statutory voluntary sector partners. Of course, this has got to involve the very kind of local BCS, as people have pointed out already. And we'll be working in order to support transformation and implementation of the community mental health framework. Of course, we'll be sharing and spreading learning as we go through. So I'm sure you'll be able to expect kind of further publications, discussions, webinars, events where we can work through and share and talk about and discuss what we're learning, so that we can support systems more widely as they go through their journeys. Next slide. I think that's it. Yeah, thank you. So the contact detail for the unit, the contact email address for the unit is on there, so do feel free to get in touch. And that's it from me.
Thank you, Becky, and thank you, Jed, and thank you, Renika. And I think if there's one theme running through everything that you've said and that Claire said, it's that however challenging it seems to have to transform and find a new way of working, unlocking the power of all of us is alchemy in finding the assets that we need in the community to really make the difference, reach everybody wherever they are with whatever they need. Now, we had Claire for a bit longer than we expected and took some questions for her. So I think rather than kind of squeeze in some excellent questions which have been sent in here on the pandemic and mental health trends, on how to involve the community in decision making as well as delivery and other things, what we'll do is we'll send round some sort of a Q&A on that after this event, rather than do 10 seconds from each person. But thank you, a huge thank you to all of our speakers, to Claire, to Renika, to Jed for some slides that seem to have made a huge impact, and to Becky as well. Please do have a look at the publication. We'll carry on publishing our guides, sharing our thinking, but also wanting to hear yours as we all go together into this incredibly exciting transformation. So I'll stop there. We'll end on time. Thank you all so much for being here today, and do expect a Q&A with some answers to your brilliant questions. Thank you.
Thank you. Bye-bye. Thanks.